One of the questions that comes up clinically, I can chime in later, but how often have you had to do like a second endoscopy? Now, obviously, you've been part of the trial, so you may have had that as a protocol. But from a clinical perspective, do you have to go back in often and take another look before you discharge the patient? Has that evolved over time? Are you doing that less now than compared to in your early years? That's a big question that I think. Initially when we are nervous about new technology and we're shifting paradigms, I'm sure the audience would love to hear your thoughts on that.
Yeah, it's a hot topic because we've been discussing this recently. When you look at these rebleeding rates, Vivek, I don't know about your center, but they don't resonate with what happens in my hospital. We don't routinely tend to go in and have another look on patients prophylactically, but also we are not seeing the rebleed rates that certainly at UCLH that some of the registry data suggest. For sure, in a cohort of patients that might be the case, but the next for Mohs replacement next year, one of the things that we're going to look at is just what's been happening to these things year in, year out. What's happening? How is our practice evolving over the years? And we've done this with RFA and EMR to see has our approach changed over the years and have our outcomes changed. And my instinct is that we are all getting more diligent about how we resuscitate these patients at baseline. And as a result, I think our index endoscopy is improving because we're now appreciating that actually out-of-hours endoscopy is not a lifesaver always. So we're doing these patients when the sun comes up in our units with our nurses. And as a result, I think our hemostatic techniques, along with all of these novel modalities like Hemospray, is getting better. And I feel that the data may well show that our rebleeding rates are actually a lot lower than they were historically. And I don't know how that resonates with your instinct.
Yeah, as I said, I think I let you go first because I didn't want to bias you with my comment. But I think that it has been our clinical practice almost never to look back because of making us feel better. Now, obviously, if the patient is clinically demonstrating signs of bleeding or something's not fitting the we anticipate blood loss, then I think we'll definitely go in. But it's a relatively rare patient, whether it's ERCP related bleed or an endoluminal bleed or post endotherapy bleed, which we'll get into a little bit. The patient's got to show us something to go back. There are very extenuating circumstances in which we go back in after standard endotherapy. And I'm sure those same rules would apply, but that would be on a rarity scale. It would not be. Now, it is a hot topic, and I think it deserves further study. I think most of the studies have shown that the clinical judgment and the rationale that we use on a daily basis are probably more than enough in making those decisions.